Hello, everybody, and welcome. I'm going to share my slides here quickly. All right. I just want to thank all of you for being here today. My name is Jennifer Blank, and I am here with Chris McCain, and we are from the University of Washington, and are going to take some time today to talk a little bit about the work that our lab is doing to attempt to address the unmet needs of caregivers in the treatment of serious mental illness. Before we begin, I do just want to let you know that you should see a Q&A box on the right-hand side of your screen. Feel free to introduce yourself in the chat and send any questions you have into the Q&A box, and we will address as many of those as we can at the end of today's session. And then you should also receive a prompt at the end to complete a post-session survey, and we'd really appreciate if you would take a moment to do that. So before we really dive in, I want to begin by acknowledging those individuals who have really been spearheading the work that we're going to be talking about today, and who have dedicated themselves to really refining these efforts over the past few years. This includes Doctors Maria Monroe-DeVita, Sarah Kopelovich, and Akansha Baswani Bai. I'd also like to take a minute to introduce ourselves. As I mentioned, my name is Jennifer Blank, and I am a research coordinator in the Spirit Lab at the University of Washington. I help predominantly on our cognitive behavioral therapy for psychosis training and implementation projects, but I'm also the event coordinator for Psychosis Reach, which is one of the family training programs that we'll be talking about today. Chris, do you want to introduce yourself?
Thank you, Jen. So like Jen, I work for the University of Washington Spirit Lab. I'm a research coordinator, primarily supporting our training and evaluation program for programs of assertive community treatment, or PACT teams in the state. But I've also been involved in a number of the family initiatives that we'll be talking about today.
We also wanted to recognize Matthew Christensen, who isn't here today, but who has helped on a number of the projects that we'll be talking about, as well as today's presentation. So as I mentioned, we are part of the Spirit Lab, which is housed within the Department of Psychiatry and Behavioral Sciences at the University of Washington. And Spirit stands for Supporting Psychosis Innovation through Research, Implementation, and Training. And our team is comprised of a number of faculty, continuing education specialists, trainers, research staff, program coordinators, and an administrative support team. And really, our lab is committed to improving the care of individuals who have or who are at risk for a serious mental illness. And the faculty in our lab since 2006 have really worked to provide training and consultation to agencies across Washington state to better support sustainable implementation of evidence-based practices that can substantially enhance the recovery of individuals living with mental illness. So with that being said, we are again honored to be here with you all today to share some of the work that our lab has done in both developing and scaling up a few different programs intended specifically for family members and other caregivers of a loved one experiencing serious mental illness. So during today's presentation, we'll start out by talking a bit about the family's historical role in the mental health system. We'll then provide an overview of our current family and caregiver initiatives that are happening across the lab. And then we'll take a moment to talk about the future directions of each of these programs. And I'm going to turn it over to Chris here to talk a bit about the terms that we'll be using throughout our presentation.
Thank you so much, Jen. So just to get everyone on the same page about the context with which we'll be using some terms throughout the presentation, we figured we would start with some quick definitions. So throughout the presentation, you will hear us refer to caregivers. In this case, caregivers are those unpaid family members, significant others, or other close support network people to someone who is experiencing psychosis. You'll also hear us use the term loved one. In this context, that's generally referring to the person who is themselves experiencing psychosis. And lastly, when we say psychosis, what we're really referring to is a collection of mental health symptoms involving disruptions in the experience of reality as it is typically understood by members of that person's culture and subculture. So this can include a range of symptoms like hallucinations, which are sensory perceptions like hearing voices that are not shared by other people in their vicinity, delusions, which are fixed, unusual, or illogical beliefs that someone may hold, as well as disorganized thinking, behavior, or communication. While psychosis and psychotic-like experiences are quite common in the general population, specifically in this presentation, we'll be talking about the subsection of people whose experience of psychosis is persistent or distressing enough to warrant treatment and is typically occurring in the context of a mental health diagnosis like schizophrenia, schizoaffective disorder, or a mood disorder. And then before we jump in, we just want to acknowledge the scope of what this presentation is and isn't, and give some shout outs to people we owe a debt of gratitude to intellectually in doing this work. So first, we hope to make the case for you all why this is important, but these projects focus on the needs and experiences of caregivers specifically. However, the general mission of our lab is around the recovery of folks who are directly experiencing psychosis. So we do just want to take a moment to acknowledge the resilience and accomplishments of those people. Lastly, doing this sort of work and being able to speak about and have an audience for it is really made possible by the activists, thought leaders, and disruptive innovators within the mental care service recipient community. So that's generally speaking the peer movement, which we'll talk more about later, who have really transformed the conversation in mental health care to be more recovery oriented and to value lived experience. Great, so before we dive in, we just wanted to share a quote with you to really ground everyone in the humanity of what we're talking about. So this is one of dozens of quotes we could have chosen from a caregiver we were working with that we feel really captures the experience of isolation and confusion that they felt upon reflecting on their first experience with the mental health care system. So this mother wrote, "I knew something was wrong with my son, and so I took him to the doctor, took him to a doctor, and then I felt like no one was listening, no one was helping me. And I'm feeling all alone, and I'm basically begging. I know something's wrong with him, that he's changing, but no one would listen to me. My family and we felt really alone because we didn't know what was happening to his brain, if that makes sense. I mean, where did he go? It was hard to talk to doctors. They were unable to speak to you." So as we think about doing this work, we can look to the literature base to see why it's important to involve caregivers. So we note that up to 90% of individuals with psychosis remain in close contact with caregivers. We know that caregivers provide emotional, financial, and social support, and in some cases may be the only source of such support. International treatment guidelines for best practices in the treatment of schizophrenia spectrum disorders include the delivery of evidence-based family interventions. However, despite this, most studies of the population of people experiencing psychosis find that a significant minority of families receive any targeted interventions for supporting their loved one. And this is unfortunate because that same literature base also shows us that caregivers have a powerful positive impact on recovery. So when caregivers are involved, we see better outcomes in treatment for their loved one, including fewer hospital admissions and reduced relapse rates, typically operationalized as returning to the hospital. When people do go to the hospital, it tends to be for shorter periods of time. We see overall improvements on measures of quality of life. We see better performance in work or other important social roles, like being a parent or spouse. We see reductions in substance use, as well as some preliminary evidence that it may improve mortality rates and prevent premature death. And part of the reason why we think this is the case is that caregivers occupy a really unique and powerful role consisting of a number of different domains. So we've outlined some of them on this slide, but just talking through them briefly, caregivers are often advocates, both in the broader community as well as within a mental health care treatment setting for the rights, dignity, and preferences of their loved one. We see them often taking a role as treatment navigators, helping their loved one find care, fill out forms, and do whatever else is necessary to receive treatment. We see them in the home and assisting in treatment adherence, so taking medications, doing therapy homework, anything else to support recovery. within their relationship with their loved one, that in and of itself can be very healing as they provide emotional support, affection, unconditional positive regard. Caregivers can also serve as early warning systems for signs of relapse and can help head off things if they appear to be heading in that direction. And lastly, caregivers are able to help their loved one connect more broadly to social networks and support. Despite this, however, caregivers face a lot of challenges in these roles. First, they may not know a lot about psychosis and may lack necessary training to identify key aspects of it. Within the mental health care system, they have been historically undervalued and may not be included, as well as just the mere fact that providing care for a loved one diagnosed with a potentially stigmatized and disruptive condition can be isolating, and they may not know who to turn to for support. So that's not to say there's no work being done on the caregiver front. There is, and much of it is fantastic. So we just want to acknowledge some of those in the state as well as nationally. So NAMI, or the National Alliance on Mental Illness, has long been at the forefront of providing family services. They are a forum for connecting with groups led by other caregivers and receiving high quality education about mental illness. Coordinated specialty care programs, which focus on people in the early stages of experiencing psychosis, are typically designed with a specialist who focuses on delivering education and support to families. Within Washington State, that's referred to as the New Journeys Network, as well as other settings that focus on treating people with psychosis and other serious mental illness may provide multifamily groups or other avenues for delivering education about psychosis. Outside of formal care delivery, we also want to acknowledge the fantastic grassroots advocacy organizations that continue to change the conversation around serious mental illness. So we want to acknowledge our friends and partners over at Chad's Legacy Project, as well as the Mothers of Mentally Ill, for their work in advancing this conversation. But of course, we recognize that more can be done, and it's into that space that we hope to step as a lab with some of these initiatives. And as we think about shaping the work that we're doing, we're really guided by three core principles. The first, of community partnership, is really reflective of the fact that if we're going to develop a program and try to implement it, it really needs to be something that is desirable, palatable, and useful to the people we are attempting to help. So that means that at every stage of the development and evaluation process, we intend to include caregivers and reflect their voices. The second, of caregiver empowerment, acknowledges the tremendous power, drive, and expertise that caregivers already bring to the role, and focuses on how any initiatives that we roll out can really build upon that and raise them to the level of community leaders as well as paraprofessionals, in a sense, in the mental health workforce. And lastly, given our lab's focus on implementation science, we really take a system-wide perspective and think about, as we develop these initiatives, how they can be scaled and evaluated in a way that is sustainable and evidence-based. So with that, I'm going to turn it back over to Jen to talk about the first two, I should say, of the three initiatives we'll be talking about, Psychosis Reach.
Thank you. So before I jump into Psychosis Reach, I just want to start off by recognizing our colleagues and our Psychosis Reach co-developers that we've really been working with over the past 4 years to refine our training and implementation model to what it is today. And this includes Dr. Kate Hardy, who is a licensed psychologist at Stanford University, and who has led multiple trainings and workshops in cognitive behavioral therapy for psychosis to a wide variety of audiences, including family members. And of course, Dr. Doug Turkington, who is a psychiatrist and professor of psychosocial psychiatry at Newcastle University, and who developed and over the last 30 years has been testing CBT for psychosis. And so we have just been incredibly fortunate to work with these two individuals for the past few years. So I want to start off by talking a little bit about what our Psychosis Reach training consists of. And as Chris just just shared a little bit earlier, we're really seeing that caregivers are in need of support, not only to better care for their loved one, but also to care for themselves as well. And so this is really the primary goal of Psychosis Reach, is to provide caregivers with this support and with this community, to provide them with accurate information about psychosis and about recovery, and to train family members in evidence-based skills rooted in CBT for psychosis that they can use to better communicate and relate to their loved one. So along these lines, I just want to talk briefly about these 3 objectives that you see on the screen. The first of which, as I mentioned, recovery-oriented psychoeducation. And so here, what we're really trying to do is help family members separate out fact from fiction about psychosis, and to be able to call out common myths and misconceptions about individuals experiencing psychosis. And so we work to really teach family members accurate information about psychotic disorders, but also share the latest research so that we can really ground their hope in empiricism. And then we also share with them a culturally informed and cognitive behavioral model for better understanding psychotic experiences. And this includes educating family members about what our nation prescribes as a standard of care, so that families can become both more informed consumers as well as consumer advocates. This next piece, caregiver self-care. So here we're really applying the cognitive behavioral theory and therapy to both psychosis, but also to the caregiver experience. And we emphasize that CBT and self-care skills are just as critical for the family member as it is for their loved one with a diagnosis. And then finally, coaching family members in CBT for psychosis-informed skills, which we refer to as the first skills. And so really, we're working to teach family members these CBT skills that they can use to support their loved one experiencing psychosis, but they can also execute without a lot of training. And it's really important that we clarify here the roles and boundaries of Psychosis Reach and of the family member. And so this training is not intended to put the family member in a position where they're acting as a therapist to their loved one, nor is it intended to replace treatment. We also don't use the training to offer individual consultation or therapy to family members, but instead what our training is really intended to do is to really create a safe space where family members can come together to co-learn and to connect with each other. So I want to briefly talk about the first skills, the CBT informed skills that we're really teaching family members, and that is a large component of the Psychosis Reach training. So of course, we think of first both as a mnemonic for the CBTP informed skills, but it's also really a way that we communicate to family members to try these skills first. And so these skills are really intended to build on one another and are also strategies to help the individual both be with their loved one, but also provide them with techniques so that they can engage in more therapeutic encounters. And so the first of these skills is F, which stands for fall back on the relationship. And here we're really talking to family members about the fact that we can't do anything helpful from a position of conflict. And so instead, we're encouraging family members to identify and to take stock in their loved one's strengths and shared interests. And this really sets the stage for being able to develop those shared goals that are shared between the caregiver and their loved one. And then an especially important part of this is normalization. And we're really teaching family members that normalization is the antidote to stigma. I stands for inquire curiously, and here we're encouraging family members to drop their assumptions about what their loved one is experiencing and to just really get curious about those experiences. So we encourage family members to ask open-ended, curious questions, which might sound something like, tell me more about what it sounds like when the neighbors are communicating with you. And it's important here that we're making this distinction between curious questioning and collusion, which is when we're buying into what our loved one is telling us. So a collusive statement might sound more like, tell me what the neighbors are saying. R stands for review the information and put it together. And here we're really trying to help family members make this connection about the ways that they think and feel, how those might affect behaviors, and how those behaviors may contribute to their own feelings of distress or overwhelm. And then it's important here that we're also teaching caregivers that this pertains not only to themselves, but to their loved ones, and how their loved ones are thinking and feeling and behaving may be contributing to increased distress or more acute symptoms. And we really teach them this information so they can share this with their loved one. S is skill development, and this is exactly what it sounds like. We're really working with family members to help encourage the use of skills their loved one might already be using that are effective, or in really reinforcing skills that their loved one might be learning in another treatment setting. Again, we're not teaching family members how to teach their loved one new skills, but really just reinforcing some of the skills that they already are using. And this might include cognitive and behavioral skills, and of course, problem-solving skills. And then finally, an important piece with the skill building is really to try out the skill and to get feedback. And so we really want families here to not only encourage their loved one to try out the skill independently, but to come back together afterwards and talk a little bit about how that went. So now that I've talked a little bit about some of the content of Psychosis Reach, I do just want to provide an overview of what our current training model looks like. And so family members receive access to an online self-paced course that takes about 5 hours to complete. And it really consists of a number of modules led by Dr. Turkington that touch on those 3 objectives I mentioned earlier. Following completion of the course, family members attend a live training event. And of course, this is all happening virtually now via Zoom. And this live event consists predominantly of role plays between a family ambassador, which I will talk about in a moment, and one of the co-developers of Psychosis Reach. And this is really intended to be a time when family members can watch how other families have applied the skills to their own loved ones in their own situations. And then of course, we have opportunities for Q&A throughout the live event. Following this, family members receive access to a community board where we encourage them to connect with other caregivers who have underwent the Psychosis Reach training, which we have family members from across the state and even internationally. And then they also receive access to a resource repository and the family ambassador contact list. And I am going to put a pin for a moment in this little purple box you see off to the side, because when we get more into talking about the Psychosis Reach family ambassador role, I will get into that. I do want to take a moment to know what really makes Psychosis Reach novel, and that's that we're taking the intervention out of the clinic and bringing it directly to the families in their home. And this has been really critical for our training efforts because we've been able to reach a large number of caregivers, including those who might not be connected with direct clinical services, or those who might not be able to get into the clinic for a number of reasons, or even those who might be going through this experience for the first time with their loved one. And so we have found some positive outcomes in relation to Psychosis Reach. And this paper that you see on your screen really details some data from our inaugural Psychosis Reach training, which happened live in person in Washington State back in 2019. And you should be able to download a copy of this at the bottom of your screen. It was uploaded with our training materials. But today I want to focus a little bit more on the data that we're seeing now with our new completely virtual training model. And so just to orient you a little bit to how we're collecting data, we're really just administering a survey to trainees immediately before they receive access to that online training course, immediately following the live event, and then also at 4-month follow-up. And we're really seeing a number of positive outcomes following the training and that are persisting to that 4-month follow-up. This includes improvements in a caregiver's experience with caregiving across a number of different dimensions, including their perceptions of stigma or the effects of the diagnosis on their family. This includes an increased reporting of positive personal experiences with their loved ones, a decrease in reported problems that they're experiencing or that the loved one might be experiencing with services, as well as some different behaviors that family members were perceiving to be difficult. We're also seeing a decrease in both depression and anxiety, both following the live event, and which is also being sustained at 4-month follow-up. And as you can see here in this graph, before the training, we're seeing levels of anxiety that are at that borderline abnormal range. And we're seeing those levels really drop below that range and sustain at the 4-month follow-up. And then we're also seeing more pro-social and recovery-oriented views of psychosis. The last thing I want to mention here is we ask family members about their comfort in using those Psychosis Reach first skills with their loved one. And while we're seeing this increase kind of across the board of all those skills following the training, we're also seeing that sustained at the 4-month follow-up. This data has been especially important because it's really informed what our Psychosis Reach Family Ambassador program is, because our goal here has really been to help family members continue to practice these skills following the live event and just have that ongoing support. And so with that being said, we developed the family ambassador role. And as you can see in this chart on the left-hand side of your screen, a Psychosis Reach family ambassador is really serving in a number of different roles. So of course, they're helping families with communication skills and problem-solving skills, which are really those first skills that we talked about. but they're also reinforcing the other information that we're sharing in the training, which is this recovery-oriented psychoeducation about psychosis and the importance of coping skills for both themselves and for their loved ones. And then, of course, emotional support by connecting with other families with similar experiences. I do want to make a note of what our Psychosis Reach family ambassadors are not, and that is they are not expected to serve as case managers or therapists or family navigators to the individuals they're working with, and they're not expected to counsel a family in de-escalation techniques or to address any other crisis or safety issues. They're also only intended to make themselves available within their own limits, and on-demand access is not a requirement for this role. So family ambassadors can meet with other families who have underwent a Psychosis Reach training in a number of ways. That is through ongoing groups, which include a number of family members who have went through the training, who might be then meeting together to do their own role plays of the first skills. This could be one-on-one with a family member, or this could just be a small group training where they're reviewing the first skills, and this may or may not include follow-up. So we are very excited to announce that we have begun working with our second cohort of family ambassadors. While our first was only families from Washington State, we now have a number of families from across the country who are part of this program. And so I briefly want to talk about what our new family ambassador training model looks like. So of course, as I mentioned before, all family members have first attended a Psychosis Reach training, both the online modules and the live event. And after the live event, they receive access to an online application. And once they complete that, we really reach out and encourage them, if they have not already, to connect with the current family ambassador so that they can begin practicing those skills and applying them to their own loved one before they begin working with other family members to support them in doing the same. Following this, family members attend monthly consultation calls for 1 year, which is led by our team and specifically by Dr. Akanksha Vaswani Bai. And we kind of use a flip the classroom style learning here. So as you can see on the right-hand side, we have really an online repository of resources and materials for families to access, but we really try to use these consultation calls as a moment to also do role plays over the first skills or over barriers that might come up in encounters with other family members. And then of course, we ask family members to attend a second or even third live Psychosis Reach event. And we really have found that family members have repeatedly reported that attending that second or third live event really helps them to feel more confident in their own skills and to retain more of the information taught in those training. Before I pass it on to Chris to talk a bit about the Family Bridger program, I do want to talk a little bit more about the ways that Reach is expanding, as well as some of the future directions for this training. So as I mentioned before, Psychosis Reach was originally intended to be an intervention that was taking place outside of the clinic. And this was really for a number of reasons. As I mentioned, both to reach families who weren't connected to services, but also just as a way of sidestepping any other issues that sometimes arise when we do have clinic-based interventions. However, what we've been seeing is that embedding Psychosis Reach in clinical settings is really a cost-effective way of enabling evidence-based family interventions. And this is partially because so much of the expertise is then coming from our team and from our online training modules led by Dr. Turkington, and thus reducing the burden that would otherwise be on the clinical team to teach those skills themselves. So along these lines, in the last legislative session, there's actually bipartisan legislation, which is known as Senate Bill 5807, that if passed would have enabled the Psychosis Reach training package along with the designated family bridger, which we'll be talking about in a moment, really to be embedded in every Washington state hospital. And although the bill passed the Senate unanimously, it did so in the House. However, we still remain committed to pursuing different avenues that we can use to implement in clinical settings. And so toward that end, we are actively working with international colleagues in Pakistan, including with the president of the World Psychiatric Association to implement Psychosis Reach at Fountain House. We're also working with Dr. Kate Hardy at Stanford University to implement Psychosis Reach in their early psychosis clinic, which is known as the Inspire Clinic. And then in addition, Psychosis Reach is undergoing a few different cultural adaptations right now. One of those is for Muslim Pakistanis with the group we mentioned above in Lahore, Pakistan. We're also doing an implementation or an adaptation for Spanish-speaking Americans, and this has namely consisted of interpretation and translation of our training materials, but we are also beginning to work with a group in Puerto Rico so that we can do a more comprehensive adaptation for Latinx populations. And then finally, we're working to also leverage technology so that we can really continue to support caregivers in using and practicing the psychosis reach skills even after they complete their training. And so specifically, we are doing this through the development of a new tool known as iReach. And just briefly, iReach is really intended to allow family members to practice responding to a simulated loved one, and then they receive feedback on those responses. And it is something that they would have on-demand access to and could go in and practice as often as they would need to in both a safe and private environment. All right, and with that, I will pass it over to Chris to talk about the Family Bridger program.
Thanks, Jen. So the Family Bridger program is another of our caregiver-focused initiatives. So again, to start, I think it's always helpful to start with definitions. So really, what are we saying when we talk about a Bridger? And this conversation really begins with the rise of peers in the mental health workforce. So the deinstitutionalization movement began in the 1950s and 60s in the United States, where advances in medication, psychotherapy, as well as a more sophisticated moral conversation about the rights of human beings in society led to the closing of a lot of long-term inpatient mental health systems. In that, a lot of that conversation was shaped by peers. So peers have evolved to be many things, but in this context, individuals living their own journey of recovery who provide support and advocacy for people receiving mental health services. Oftentimes, they deliver these services alongside other clinicians or clinical teams and undergo their own training and certification process, as well as have a broader connection to advocacy and change organizations. So peer bridgers are a program that have been around for a while now, in which someone who has been hospitalized, often newly hospitalized or early in the course of their diagnosis, are paired with a trained peer bridger who helps them navigate and move into a new reality after hospitalization, who's able to kind of walk beside them as they begin this journey of recovery. And these programs have historically targeted the person who is themselves experiencing the mental health crisis or carrying the diagnosis. However, there is evidence to support a family bridger type model in which it is the caregiver who receives the bridger services from a family peer. So there is an evidence base to support it that is based on not psychosis specifically, but a juvenile general caregiving experience of parents caring for younger children who are experiencing more broadly defined emotional disturbances or behavioral disruptions at school. So in those studies, people have found that families receiving a family bridger type model are more likely to initiate mental health services. They're more effective in navigating and obtaining the services, and they use more of these services once they find them. We see they expect greater benefit from their loved ones' involvement in care, and this is especially true for caregivers who report really high levels of strain or burnout. After receiving family bridger type services, families report higher sense of empowerment, higher senses of knowledge, as well as reductions in stress level while caregiving. Beyond that, critically, they have an increased perception of both social support as well as tangible logistical support in navigating their caregiving needs. Interestingly, for the loved ones themselves in these models, there is evidence that they receive benefit from the family bridger type model as well. So we see moderately improved academic functioning, as well as increased school attendance, lower rates of school suspension, higher rates of engagement in mental health services in these kids. However, as we mentioned, these programs are not psychosis specific. So that is kind of where we came in with our vision, which is to develop a family bridger type model that is specifically focused on supporting caregivers for people who are experiencing psychosis. So we did receive funding for this pilot project from anonymous donation, as well as through the Washington Healthcare Authority, as well as the Northwest Mental Health Technology Transfer Center, which provides training and technical assistance to the mental health workforce. So in the spirit of our community partnership goal that we mentioned earlier, before launching any sort of pilot, we held 6 focus groups across Washington state that were co-facilitated by a member of our team, Dr. Maria Monroe DeVita, as well as a family caregiver. We recruited 58 caregivers across the state who were asked to reflect on what would have been helpful at the time of their loved one's first hospitalization and how they might imagine a Family Bridger program meeting those needs. So after conducting thematic analysis of the transcripts from those interviews, we identified 5 key domains or function of the Family Bridger. And we've included an illustrative quote for each of these if you're interested in reading them, but I'm also just going to talk through briefly what each of them are. So the first is resource provision. Caregivers wanted someone who would specifically provide them with more information about where to access care, as well as information about where they could learn more about their loved one's condition. Advocacy, so people were interested in Family Bridgers advocating for them at both the systemic level of ensuring that hospitals were adequately meeting their needs and behaving ethically, as well as more in the individual dynamic with clinicians. So someone who is really going to amplify their voice and help them bring their concerns to the care team. The third was interpersonal support. So again, that powerful experience of being able to connect with someone who knows what you're going through, who can be a knowledgeable ear for you to share your experience with. Sort of in the realm of what Jen was talking about with Psychosis Reach, someone who could help them develop the skills and expertise needed to effectively step into this new stage of their relationship with their loved one and respond to possibly psychotic symptoms that may have been previously unfamiliar to them. And lastly, providing education about mental health diagnoses as well as psychosis. And we added this caveat of collaboratively decided because a theme that emerged in this was that while people are often provided some level of education in clinical settings by a care team, it's often overwhelming. So they really wanted someone who is able to sort of be a dimmer switch in providing as much education as they were able to take in at the pace that they were able to hear it. And then they could return to that relationship and kind of go over things or get more information as needed. So with that in mind, best laid plans, we decided that we were going to do a pilot. It was going to be in line with sort of that initial history of peer bridgers, where it would be kind of a first contact with the hospital program. However, as I'm sure everyone in the audience is aware, the COVID-19 pandemic led to a change in pretty much everyone's plans. So hospitals restricted their access to inpatient units for everyone's safety. So with that in mind, we made some key adjustments to the model. So the first was that it shifted to telehealth only to minimize the possibility of exposure to COVID-19. We decided that rather than embedding in inpatient settings, we would work with the New Journey's first episode psychosis team. So again, still targeting people early in their diagnosis of a psychotic disorder, but not just right at that first contact. And then the Family Bridgers were to be UW volunteers who had gone through the Psychosis Reach training program, and that this would be a small pilot really focused on evaluation so that it could be further honed and expanded in the future. So this is a general overview of what the process was. So family members who were receiving services at the New Journeys programs were identified, consented, and recruited by UW research staff from our team. They were then connected to one of 3 family bridgers who had undergone a training process with us based on an initial manual that we had developed as a team based on those 5 tenets of family bridger functions. Then they met with those family bridgers up to once a week for up to 10 times over a period of 20 weeks, collaboratively decided with the family bridger about when those would happen, when it could be fit into their schedule. They underwent evaluation, both the family bridgers as well as the caregivers at the midpoint and the end, as well as extensive exit interviews, all of which were to be coded for program evaluation. So based on that evaluation, we do have some preliminary results for caregivers in the Family Bridger program. So at the end of the program, these caregivers reported that they had a better understanding of mental illness, a better understanding of the resources available to both them and their loved one. It increased belief that they had an ally in the mental health care system who was really on their side, more confidence in their ability to support their loved one, reported better communication with their loved one as a consequence of participation in the program, as well as reported that they themselves had developed better coping strategies for managing their own distress. And then when asked about those 5 domains we talked about earlier, to rate the degree to which those services were delivered, on a scale of 1 to 7, with 1 being poorly delivered and 7 being excellently delivered, the average across all ratings was near excellent, so over 6. And 100% of the caregivers involved in the program reported that they would recommend this program to others. So as we think about the future directions for this program, we continue to be in a period of active analysis of our preliminary findings. We are coding responses from interviews, as well as looking at more data. Moving forward, we hope to pilot, as originally imagined, this program in hospital settings at the time of first contact for a loved one experiencing psychosis, as well as to continue to expand and deepen this program's relationship with coordinated specialty care / New Journeys teams in the state. Within that, we also hope to train additional family bridgers, as well as develop a more formal training and certification process. We also want to acknowledge that aspects of the Psychosis Reach Family Ambassador and the Family Bridger program might sound very similar, and wanted to just give you this slide to sort of summarize the ways they're similar and different. So beginning at the bottom, both of these programs operate from a shared framework of being based in an evidence-based, recovery-oriented understanding of psychosis. Everyone goes through the REACH training, so they're trained in cognitive behavioral therapy for psychosis-informed communication skills. And both programs are really intended to reduce the feelings of isolation, stigma, and historical disenfranchisement of caregivers in the mental health care system. However, they do differ in a couple key domains. So their primary focus, first of all, the Psychosis Reach Family Ambassador is really seeking to provide caregivers with nodes of further learning where they can deepen their understanding of REACH skills as well as practice their implementation. Family bridgers are a little bit more relational and looking at this transition period in people's lives, helping this caregiver navigate a new normal where they'll be supporting their loved one as they embark on a journey of recovery from mental illness. The location in which the services are received. So Psychosis Reach Family Ambassadors are based in the community and have a lot of flexibility about when and how they recruit people, whereas the Family Bridgers are embedded within a healthcare system. So in this case, it was in the New Journeys programs, but in the future, we hope to be in hospitals as well. And lastly, in terms of their current status, so as of right now, Psychosis Reach, as well as the Psychosis Reach Family Ambassador program, continues to be available to the public, whereas the Family Bridger program, we have just completed the pilot, still evaluating data, and are pursuing funding for further implementation. The last thing we just wanted to touch on very briefly was just that we've collected a lot of data over the course of these projects and are looking for ways to further use it to inform other initiatives in our lab. So one such sub-project is one comparing the perceived needs of English and Spanish speaking relatives of individuals experiencing a first episode psychosis. So the reason that we were able to do this was we had sort of the unique circumstance of the 6 focus groups we conducted for Family Bridgers, 2 of them were conducted in the same town, one of them in English, one of them in Spanish. So it really provided a snapshot of the people in a neighborhood who ostensibly had access to the same resources, but by virtue of language preference may have had very different experiences. So here's a quick breakdown of the comparatively small number of people that we had in these 2 groups. I just want to quickly note that the vast majority of them in both groups were mothers, and a significant proportion of both groups did identify as Latinx or Hispanic. So we just feel that these results that we're about to present on might be a little bit more reflective of language preference and comfort rather than necessarily ethnic identity. So in analyzing the conversation between these 2 groups, as expected, there's a lot of commonality. Both groups felt that the first hospitalization experience for their loved one was overwhelming, that family members were not consulted in clinical decision-making by the clinical team. HIPAA laws, so healthcare privacy laws, were challenging to navigate, especially when psychotic symptoms contributed to a loved one perhaps not trusting a family member or just not wanting them involved. Lastly, both groups did have access to the New Journeys Coordinated Specialty Care Program in the area, which provided bilingual services, and both felt that that was very helpful. However, there were a couple differences in themes that we noticed emerging across 3 domains. The first around information availability, whereas the English speakers felt they were able to access high quality clinical information in clinical settings, as well as in community-based organizations like NAMI and some of the other ones we mentioned. The Spanish speakers felt that their avenues for getting information were limited to clinical settings where translation was available, and were not able to find comparable Spanish-speaking resources in the community. In terms of proposed or imagined educational campaigns that they would recommend, English speakers focused on deepening and broadening the information available in clinical settings, maybe in a more multimedia format from different staff members, whereas the Spanish speakers talked a lot about the utility of public health campaigns in the community. So they mentioned specifically potentially a high school education campaign that educates not just the students, but their family members and extended family by proxy as well. Lastly, when talking about clinical goals for the family, the English speakers were more narrowly focused on the recovery of the person experiencing psychosis directly, whereas the Spanish speakers, who of course were also focused and talked about that a lot, brought up much broader concerns about the impact on the other members of the immediate and extended family. So issues like needing to explain it to relatives, cousins, the impact of the diagnosis on siblings who don't share the diagnosis, as well as the strain and difficulty in navigating caretaking burden within marital relationships. And we feel that these results might help to better inform coordinated specialty care delivery in Washington State and potentially beyond. So with that, we want to thank you all for attending, and we want to open it up to any questions you might have. You can also feel free to go to our website to learn more or use any of the included email addresses or contact information on our website to learn more about these programs or ask more about what we do in the Spirit Lab.
Thank you, Chris. So it looks like we have a little over just or right about 10 minutes for some Q&A. And I have received a few questions in the chat that I will start with, but please feel free to enter any more into your Q&A box. Okay, so the first one that I'm seeing is, I'm wondering if you would be accepting Washington caregivers in the future for research. I would start by saying definitely. Some of the research that we've currently been doing, I mean, we had some research efforts that were taking place through Psychosis Reach, and so that was really embedded into the training process. I think some of these focus groups that Chris kind of talked about was something that we had done previously to inform the family bridger model specifically, but that's not to say that there's not other, future similar kinds of focus groups or other research efforts. So for that, I would definitely recommend just emailing us, and either at that Psychosis Reach email you saw, or our overall lab email is uwspirit@uw.edu. And we can just either put you on some kind of a waiting list or let you know about any opportunities that we would have at that time. I'm also seeing a question come in that's kind of more specifically asking about applying the psychosis reach skills that we were talking about to their own loved one. And I think this question came in a little earlier, and then we talked a little bit about what each of those first skills really entails. But I will say that this conference really comes at a good time, because we actually just finished our Psychosis Reach live event, our previous one, this last Friday. And so with that, we're opening registration next Monday on June 20th for more caregivers. So I would recommend going to our website, Psychosis Reach at uw.edu. And there's a list there where you can sign up to join the waiting list, and you'll be notified as soon as registration opens on Monday. But that link will also be live on our website by about 8 or 9 a.m. Pacific time as well, to register directly from the website to learn more. And just to clarify, once you sign up for a Psychosis Reach training, you immediately receive access to those online training modules. So that'll kind of jump right into, I think, this question specifically about, opening up a conversation with your loved one. That's really addressed in those modules, and that's something that you'll receive access to immediately after registering. And then the live event, which always follows that, that's not scheduled until September 16th, but that gives you an opportunity to watch the skills being applied and to also ask some Q&A questions there to the Psychosis Reach training developers. Chris, I might send this one to you. I think this is referring to the Family Bridger program specifically. And so it's asking for pilots of first episode psychosis. Would that include state hospitals in Washington?
That's a really good question. I think I would answer that by saying potentially. As I mentioned in the program, we're still pursuing funding and thinking about next steps. So we definitely do have our attention on, as I mentioned, inpatient units, which may very well include the state hospitals rather than private hospitals. But we are just we're still early in that conversation. So that would just depend on what we're able to negotiate, what they're interested in working with us on, as well as what sorts of funding we receive.
Right, I'm seeing another question come in that's asking, is there anything that can be done to help get the Family Bridger program in all psych hospitals? That bill passed through the House. What was their argument against it? So I can kind of speak a little bit towards, slightly towards the end, so we don't really know exactly what their argument against it was, but we do know that it was just a relatively short session, and there was a lot of other things being prioritized in that session. And so I just think for that reason, this time it didn't get passed through. And I know we've heard, a lot of times it takes several times before the bill is passed through. In regards to, there's a lot of chances to advocate in different states for any bills that are being proposed. So I know, for example, when this one was being proposed, we had a lot of Psychosis Reach family ambassadors who attended the live session and who gave their testimony for the bill, and really supporting it and advocating for it in that way. Chris, I don't know if you have anything to add to that. This is specifically talking about Family Bridger. So yeah, so the bill that was that went through was for both Psychosis Reach and Family Bridger as well. I'll just make note of that.
I think that's a really good summary. The only thing I would add is some of the advocacy organizations that we mentioned, like Chad's Legacy Project, as well as Mothers of the Mentally Ill, are always looking for new people to work with them. And by going on our website, you can learn more about both of them, or just by simply Googling them, you can learn more about their efforts and sort of uniting your voice to theirs if that's something that you're interested in.
Looks like we have a few more minutes if anybody has some last minute questions, but as we both mentioned before, you're welcome to go to our website to learn more about the programs, to send us emails if any questions come up later. As I mentioned before, we have some attachments to this presentation. So there should be a copy of the slides, and there's also that paper that was published on Psychosis Reach outcomes, and then also a Psychosis Reach flyer if you are interested in learning more or signing up for that training, that you're free to disseminate that as you see best. thank you all again for coming. Thank you for your questions. We're very excited and passionate to be talking about this work with you all today.
I just want to echo Jen in saying thank you. It's been wonderful to be able to speak with you all, and we really appreciate your questions and commitment to this work alongside us.
And I am just getting an alert that our remaining time is about up. So again, we're going to be logging off in a second, but please feel free to shoot us those emails. We're happy to pass those on as well to the different faculty that are working on this training if you have other questions that we didn't address today. Thank you.